And without any further ado, I'm honored to introduce our first speaker, Dr. Kristine Kuhn, who will be presenting spondyloarthritis management and research highlights. Dr. Kuhn is Associate Professor of Medicine and of Immunology and Microbiology at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. She obtained her MD and PhD in immunology at the University of Colorado, followed by internal medicine and rheumatology training at Washington University and Barnes-Jewish Hospital at St. Louis. Dr. Kuhn was named an American College of Rheumatology Outstanding Fellow in 2013. For the past 7 years, she's been a faculty member at the University of Colorado Anschutz Medical Campus, where she sees patients in a specialized spondyloarthritis clinic. And she has been awarded the SAA Burkell Early Career Investigator Award in AxSpA and is a leader in both Spartan and ACR. Welcome, Dr. Kuhn. We're so excited to have you.
Thank you. Okay. So whenever you give a talk to a new audience, it's always good to get to know your audience. And so I've worked with Eileen to put in some polls throughout my presentation this morning to kind of keep this a little bit more interactive and allow me a chance to hear from you throughout the talk. So I don't know if you want to put up the first poll, Eileen. This is the question. So hopefully the box pops up in your window and you can put in what type of spondyloarthritis do you have? Is it non-radiographic? Is it radiographic or also ankylosing spondylitis? Do you have IBD-associated spondylo, psoriatic, reactive or infectious disease? Are you a family member? Are you not sure because either your doctor didn't tell you or this is a completely foreign language to you? So I'll give you a couple more seconds to finish this. And then let's go ahead and, I don't know, Eileen, are you able to see the numbers of respondents?
I am. So we're right about 77%. So I'm going to give like 2 more seconds.
Great.
For anyone who's still voting. And then, okay. And I'm going to end polling now. 3, 2, 1.
Okay. All right, so the majority of individuals today have ankylosing spondylitis. That's good because that's really kind of the major focus of what I'm talking about. We will talk a little bit about non-radiographic, and I will talk about how it's more than just joints that this disease affects. And so we'll talk about a little bit about how we think about things beyond just the joints, like the skin, the gut, and things like that. So great. Okay. So what is needed to understand spondyloarthritis? And this is the perspective as coming from me as both a clinician as well as a researcher. And I think for making true impact in patients, we need to look at spondyloarthritis from a variety of different views. And these are the different topics we'll work through today. And we're going to start first with natural history studies, in which we look at individuals who are well phenotyped, meaning we really understand very detailed information about the clinical features of your disease. We tend to like to look at people before they become symptomatic. So people who are at high risk for developing it and prospectively following them. So following them over time from that at-risk state because of maybe genetics or family history, and prospectively following over time as they go on to develop disease, to be able to better understand what is the natural history? How does this disease occur? And this can provide a lot of information. And what we know now, this is something adapted from Dr. Atul Deodar at Oregon, who you've probably heard speak in the past. And what we know about spondyloarthritis is that there are some genetics that put us at risk. I'll put this to a laser pointer. There are some genetics that put us at risk, as well as other related conditions. For example, you may not have ankylosing spondylitis yet, but if you have uveitis, we know your risk for developing ankylosing spondylitis is greater than somebody who doesn't have uveitis. And so we think about these people who are at risk for developing spondyloarthritis as kind of living in this pool or lake. And not everybody gets out of the lake. A lot of individuals at risk never end up with disease, thankfully. And we can learn from who develops disease and who doesn't if we start with studying people in the lake. And then we want to follow and see who comes out of the lake and starts to go down either the main river towards advanced spondylitis or ankylosing spondylitis, or maybe people that leave off the river, off of tributaries of the river throughout different processes, and maybe just get non-radiographic disease and never go beyond that. It spontaneously resolves. Or maybe you just get sacroiliitis or disease just in the lower spine, and it never completely goes up the spine. And so if we can start to monitor and watch patients as they go from this kind of pool and understand which rivers and tributaries they go down, it gives us more and more information into understanding how does this disease work and how can we better treat it. I think it also gives us a lot of information on prognosis and trying to understand, when you first come in as a patient at 20 years of age, hopefully, we can start to say, okay, this is what we can expect. So as many of you probably know, the field really relies on x-rays. And so we're kind of, actually, let me go back. We know what this is. We're not so good at understanding what is non-radiographic or the spontaneous remitters, or really who's at risk. We've got some ideas, but we're not great. And where we have started at is here, and we've been working backwards. And what we know is radiographic sacroiliitis can be really hard to identify. And that's because we're looking at something smushed into a photograph, essentially, when we look at the SI joints of the pelvis. And so these are kind of those hip bones that come out and around to form your pelvis. And then this is the sacrum, which is the base of your spine. And then this is your lumbar spine kind of going up from here. The problem is that the plane changes from top to bottom and front to back. And we're just smushing it flat into a 2D. And so it's hard when you start to look at this and say, okay, where exactly? I can see the sacrum bone coming down here, but well, I kind of lose it in here and I can't really tell other than this white line. And is that normal? Is that not normal? This is a normal x-ray and it looks fairly normal. And we know that when it's advanced fused, we really don't see that line. It goes away. So here you can see kind of the white lines coming down on both sides, and we start to lose that. There's no difference between the bone on either side of the sacrum or what we call the iliac bone, or part of that pelvis that forms the hips. But when it's early on, you still get this kind of line coming down. And, yeah, it looks a little fluffy in there. It looks a little abnormal. But depending on your rheumatologist, and probably even more so the primary care doctor, it's really hard to make this assessment if you're not used to looking at these x-rays. And so x-rays can make things really, really difficult. And we've been really pushing, at least here in Colorado, is to really get our doctors to go ahead and get MRIs if in doubt or any question. The other thing that makes challenging about x-rays is that there's mimics, what we call like mimics, or things that look like spondy but aren't actually spondy. And this is something called osteitis condensans ilii, where you can get this kind of white fluffy stuff that we would associate with sacroiliitis around both of the joints on both sides. But this is something we can often see, especially in women who have recently had children. It kind of gives this bone scar, if you will, in the pelvis and can mimic sacroiliitis. So then you get really confused as a physician because you've got a young woman coming in who has what sounds like back pain that sounds like spondyloarthritis, but your x-rays look like this, and she's given birth, and you're like, well, what do I do? And so that's why we're, at least from the spondyloarthritis experts that I interact with, we all are very much in favor of just going for MRIs, because that can be a lot more sensitive and tell us if what we are or are not seeing in the bone could actually be some inflammation. And so just to kind of show you what an MRI is, and I routinely go through imaging with my patients, so hopefully your doctors do too. But this is, again, the sacrum. And then these are those hip bones coming around here. And this is normal. We don't really see, this is that joint piece right here, and we don't really see much going on in the joint. But if we go over here on this inflamed one, again, here's the sacrum. These are those iliac bones coming up and over. And you can see down in here, this is starting to light up. It gets really white. And that is inflammation. That's what we call bone marrow edema, suggesting inflammation in the SI joint there. So MRIs are really great because they can be incredibly sensitive and help us identify if those pain and the pain and the symptoms that a patient is experiencing are due to inflammation in the SI joints, and helps us go down that road of making the diagnosis of either non-radiographic or radiographic axial SPA. So what else have natural history studies told us when we look at people who are at risk and we follow them? And a lot of this has come out of the DESIR cohort, which is in France, where they take people who are at risk because they have family members with ankylosing spondylitis, or they have an HLA-B27 positive marker, and they're followed over time, kind of like I said we should do. And when we do that, we find that they find looking at people who are non-radiographic, meaning they've got inflammation on MRIs, but they don't necessarily have X-ray damage, versus X-ray damage people with ankylosing spondylitis shown here. And what have we learned? Well, we've learned that people with non-radiographic disease tend to have what we call enthesitis, so inflammation and swelling along tendons. And so hopefully you can appreciate here, this is a woman standing and she's showing us her Achilles tendons here. The left is normal, the right looks a lot more thick and swollen. It looks like she's got a pretty swollen ankle there, and that's from the tendonitis or the inflammation along that Achilles tendon in the back of the heel. And that tends to be much more common in people with radiographic disease. And this can be subtle. It can be really hard. I've had several patients who come in and we're talking about enthesitis, and they're like, yeah, but I just played golf and I just chalked it up to playing golf. And I'm like, yeah, but, and we have to keep an open mind as to, if you're getting golfer's elbow, tennis elbow, Achilles inflammation, like, is it due to overuse because of your daily activities, or is it because of this underlying spondyloarthritis? But we know if you're non-radiographic, you're more likely to have these tendon issues. What we also have learned about people with non-radiographic disease, that only 5% of these individuals will progress and become radiographic after 5 years. And we know that people with radiographic disease, as well as these people who do progress, tend more often to be men, have the B27 positive marker, and these individuals happen to use TNF inhibitors. But what we've also learned in these studies is that peripheral joint involvement, meaning joints not part of the spine, but joints in the arms and the legs, pretty equal in either type of axial SPA. Also, equally likely, regardless if you're non-radiographic or radiographic, you are likely to have organ or tissue involvement. And then finally, and I think this is probably most unrecognized by providers, is that the pain and quality of life experienced by either of these two categories is pretty much the same and equal, telling us that, regardless of radiographic damage, we really need to be going after the symptoms that patients are experiencing with their disease. So what are the unmet needs that we're learning from doing these natural history studies? So how do we move from that pool into the rivers coming out of it and understand that well-described genetic risk and link it to the pathophysiology or the biology of the disease? And are there different stages? And so this is something I borrow from rheumatoid arthritis, which we study a lot here at the University of Colorado, as well as spondyloarthritis. And what we've learned in RA is that there's kind of this preclinical period where there's risk, maybe there's immune system changes, and then we progress into stages of disease. And we don't know if in spondyloarthritis, we have that same disease progression. Do we go from genetic risk to immune system changes, to then you start developing those symptoms that we call inflammatory back pain, that morning stiffness, or that I call it gelling phenomenon, where after you sit down for a while and relax, it's stiff and hard to get going again. And then do we progress from those symptoms to this non-radiographic to then full-on ankylosing spondylitis? And we don't really know, is this a linear thing or are these different pathways from that same pool? And then I think probably the biggest unmet need for the field is accurate biomarkers. And these are blood markers, urine markers, stool markers, anything that we can utilize clinically to say, yes, no, you do or don't have disease. Our prognosis, yes, you're likely to be just non-radiographic. No, you're likely to go on and develop full-blown ankylosing spondylitis, or even to know, is your disease active? You know, you've been on your treatment for the last 2 years. Is your disease still active or not? Is this new back pain you're having related to your disease, or is it related to something else? And then would those work within disease subgroups? And so kind of my first question of what type of spondyloarthritis do you have? You know, would those markers work if you say you have Crohn's disease and you're having back pain? Well, could that back pain be because of spondyloarthritis, or could it be referred pain from the inflammation in your bowels? And so that's where biomarkers could be really helpful for us. And then of course, we always want to have better therapies. And we want to be able to get people diagnosed and treated a lot sooner in the disease course. And then something that we're really focused on here at Colorado is prevention of disease. If we know you're at risk, and by utilizing different features of your disease, we can say that you're at low risk, moderate risk, or high risk, could we do some kind of interventions that maybe have less side effects than immune modulation that we do with our treatments? Could we then prevent you from fully developing disease? So that leads me into this area of disease biomarkers as kind of my next topic to go through. And when we think about disease biomarkers, we need to be able to evaluate tissues from a lot of these well-defined patients. And so these natural history studies go hand in hand with developing biomarkers because we really need to know those fine features of people's disease. Not just radiographic, non-radiographic, but do you have skin involvement? Do you have eye involvement? Do you have bowel involvement? Things like that. And we need to start to look at individuals when they're first coming in. So this kind of gets us in a little bit of a catch-22 because it's such a long delay in diagnosis of this disease. Like, how do we get people who are new with disease to get those early disease features to help us identify these biomarkers? And things that we want to look at are blood. We want to look at joint tissues, whether it be fluid or other pieces of tissue from the joint, stool, maybe biopsies of the bowel, of the skin, things like that. So my next poll question, how important was the HLA-B27 marker for your diagnosis? So this was something essential that until that came back positive, your doctor wasn't going to believe your back pain. It was helpful, but maybe the x-rays and the MRIs were just as essential to getting this diagnosis. Your diagnosis was made before an HLA-B27 was checked. You are B27 negative, or you don't know what that is. And I'm speaking again, another foreign language. I think this audience is pretty attuned, but just in case there's a few out there that this is all novel.
So we're right about close to 70% who voted. So maybe another 5 seconds, 10 seconds. Okay, ending polling now.
Great. interesting. That I think this is a really, this was something that as I was talking with my colleagues here and preparing this talk, we were really interested to see this kind of information. And it's fairly spread apart as to, you know, who really needed this checked versus being negative for it, and it wasn't necessary for their diagnosis. So, okay, let me close this. Okay, thanks. Okay, so let's talk a little bit about B27, and I have a little cartoon here of me being on my soapbox. The reason I also asked this question is not only am I curious to to your experiences in getting diagnosed, but I also want to make sure I'm not walking into the lion's den a little bit here, because I know that there's a wide range of feelings about HLA-B27, and so I'll just give you my soapbox based on what we know. So for the 2% of individuals out there listening who aren't sure about HLA-B27, this is a genetic marker that is often present within patients with spondyloarthritis. And how often it's present depends on the population you study. So if you are studying true blue ankylosing spondylitis, you will get closer to this 95% of individuals with ankylosing spondylitis are positive for this genetic marker. Now, keep in mind that spondyloarthritis, if we combine all of them from psoriatic to ankylosing to IBD and reactive, we will find that about 2%, so 2 in 100 people will have a spondyloarthritis of some form, but just over 10%, so 1 in 10 people will be B27 positive. That tends to be higher in Western European populations. And so when we think about like our North and our Western European descendants, we tend to see a lot higher HLA-B27 positivity. When we start to go towards Africa and Asia, we start to see a lot lower HLA-B27 positive presence. This is the most studied genetic risk factor for spondy. However, even though it carries an increased risk, if you are B27 positive, you have a 20 times increased risk for getting spondy, it only explains about 1/3 of your genetic risk for getting disease. So it's not the end all be all. So if we kind of crunch together all of these numbers, I always remind people that I tell this to physicians, my colleagues, primary care docs, and when I talk with patients too, we talk about, despite this strong association between B27 and ankylosing spondylitis, 80% of people with the gene don't get AS. And 20% of people with AS, with the disease, don't have the gene. And so I think that reminds us that we have to be open-minded, that this is just one piece in the puzzle of understanding if your patient has ankylosing spondylitis or a spondyloarthritis. I have seen really, really sad situations both ways where a patient with a B27 didn't have disease, but then also a patient who didn't have a B27 had disease and didn't get diagnosed for 45 years. So I think, you know, it's important as physicians that they don't completely anchor on the presence or the absence of this test. The other thing when we think about biomarkers, we often use the MRI as a marker of disease. And one thing that we've learned from studies is that if we just do an MRI of the pelvis to look at those sacroiliac joints that we like to look at for inflammation, we have learned that there are many, many false positives. So of course, if we look in people who have axial SpA, so these are our positive controls, people we know with disease, you know, 90+% of them will have a positive MRI if we just randomly select them and put them through the machine. Now, if we just take healthy participants, or maybe especially here, women right after having childbirth and put them through the MRI scanner, we can see that quite a few people come up positive. So it's not also just the MRI. It's the combination of the MRI plus the symptoms, plus the historical context in what's going on at the time that the MRI is getting done. We also know that, as I said earlier, very few people with isolated sacroiliitis on their MRI will progress to radiographic disease. So I need to move my video screen so I can actually see my full slide here. And so essentially, if we look at people who go on to progress for ankylosing spondylitis from non-radiographic disease and get on full-on spondyloarthritis, it's about 5% of the population that does that. And we know that people who are most at risk for progressing tend to have an elevated C-reactive protein, an inflammation marker in their blood, and they tend to be B27 positive. But in spite of these studies that we're doing, in spite of knowing about B27, in spite of utilizing MRI, if we compare, about over 10 years ago, how well we were doing with diagnosis, that's in this kind of blue-green triangle and the dark blue triangle. If we look at age of onset versus age of diagnosis, so that's the delay in diagnosis, it was about a 10-year delay between those two lines. Now, 10 years after that, when we started using more MRIs and we started utilizing the information we have from natural history studies, if we look at the yellow diamond versus the green square, again, age at onset to age of diagnosis, we haven't shifted the needle much at all. And we're still experiencing at least a 10-year delay in diagnosis of this disease. So we're doing a terrible job is the basic point. And so we still need biomarkers. And so what's on the horizon? What are we doing? So I think there's a lot of excitement about these things called genetic risk scores. It utilizes things like the HLA-B27, but a lot of other genes that we have learned are associated with the development of spondyloarthritis. And if you can combine them together, it gives us a lot more information and detailed about who is at higher genetic risk than just the B27 alone. We can look at microbiome profiles. I think this is something where there's a lot of interest in understanding, is your microbiome going to predispose you for developing spondy? And we can look at other blood factors, and this is kind of a word cloud of things that have been published in the literature in the past 5 or so years that have been associated with ankylosing spondylitis. None of them have really borne fruit, but one of the things that we can start to do is put these together and say, okay, maybe CRP by itself is not good. But if we start to combine things like HLA-B27, CRP, maybe calprotectin and IL-6, maybe together that can give us kind of a relative risk score for disease, like, oh, that means you're more likely to have disease or less likely to have disease. And these things could be helpful. And I think those are things that are on the horizon and actively being pursued. I think another thing that's actively being pursued are larger collaborative efforts where those of us that are in this field of research are trying to bring our minds together, pool our resources of cohorts of individuals who have volunteered to help us understand this disease, and how do we pool all of our resources collectively and start to really go for this major unmet need of biomarkers in the field. Okay, so what else do we need to do to understand spondyloarthritis? We need to understand the biology. And so here, for this, we need to start looking at human tissues and cells, as well as looking at mouse models. What are they showing us? What are we learning from this? How does it inform these biomarkers? How does it inform the development of disease? And then how would it inform development of new treatments and prevention? So another poll. Which is most responsible for the development of spondyloarthritis? Gut health, genetics, both, neither.
We're right about 70% voted, going up quickly. And I will now end polling.
Okay. Both. Absolutely. Glad we're all on the same page for the most part. A few felt more gut health, more genetics, but yeah, and some felt neither. And so let's go through a little bit of the science behind this. So what we do know from both clinical observations where a lot of individuals will have inflammation of the gut as well as inflammation of the joints, microbiome studies, immunology studies, and genetic studies, we've come together with this gut joint axis hypothesis, where we think that maybe some of the microbes, and these are just a couple that have been of bacteria that are normal commensal bacteria, live in the normal healthy gut, that have associated with the development of ankylosing spondylitis. And we know that genetics can influence these bacteria. There was a nice study done out of Oregon that showed that the presence of B27 influences your microbiome. We also know, though, that diet influences your microbiome. And so these kind of influences can then interact. This is like your intestinal epithelium, or that lining of your intestine. And these things can interact with that lining, as well as a variety of immune cells just hanging out right there at that lining layer, ready to protect you from anything that tries to break that barrier. And we know that how these cells function are incredibly affected by genetics, as well as being affected by these bacteria. The other thing we've learned from studies is that it appears that a lot of these cells can then get into our bloodstream and go to the joint. And just for ease here, I show kind of the inflamed enthesis of a knee. But what we've learned by pulling fluid from swollen knees of people with ankylosing spondylitis is that there's cells that look like they came from the gut there. And those cells, we've learned from mouse studies that the cells from the gut learn how to make things like TNF and IL-17 because of how they've interacted here with their microbiome. But we also know that there's genetics at play here that make them maybe more prone to go down these paths. And so this gets into a little bit more of the microbiome because that's more my expertise than the genetics. But I do kind of caveat it and acknowledge that genetics are just as much at play here as the microbiome. But what we know is things like diet, probiotics, and antibiotics in both spondyloarthritis and rheumatoid arthritis, and this is just a review article that I pulled this from, and they've associated both in mouse models and in patients that there's a huge amount of changes in the bacteria of the gut that can be influenced by these things. But what's really interesting is that these things correlate and result in what we call metabolites, or products of the bacteria. And things that are really interesting is the generation of indoles. This comes from tryptophan metabolism, and I'm not going to tell you to hold the Thanksgiving turkey here, but it appears that in individuals with spondyloarthritis, this is something our group just published, it appears that we start to generate a lot more of these, and it correlates with inflammation. The other thing that we're starting to find is that there's a reduction in people with spondyloarthritis in their gut of things called omega-3 fatty acids. And these are the things that you hear of coming from like your fatty fish, plant-based fats like that coming from avocados and tree nuts. But what we don't know is that, which of these bacteria are important, and can we affect them? Can we give maybe a prebiotic? What if a prebiotic could be eating a specific type of supplement that, like fatty acids, omega-3 fatty acids. If you took an omega-3 fatty acid supplement, would it help affect your microbiota? Would it help increase these omega-3s and then have an impact on disease? We don't know that, but I think that's kind of the way that the field is trying to move and understand going beyond these correlations to functional consequences. But I think a lot of patients will ask me if I recommend supplements or changes in their microbiota. And really what I push is as much of a plant-based diet as you can do and omega-3. So whether you get that because you love to eat tuna and salmon, or if you like to take a supplement, that's great. But if you don't do it, are you doing yourself a detriment? No, we have no data to go one way or the other. So what happens? So this is what's going on in the gut, but then what happens in the joint? And this still remains a bit of a black box. From the studies, mostly again coming out of Europe, we're starting to do a little bit of this here. We know that if we pull that part of the spine that gets affected by ankylosing spondylitis, if we pull it from, this is kind of a healthy spine, whereas down here is the fused spine of ankylosing spondylitis. If we pull a little of that tissue from a healthy spine, we see that there's a balance between these kinds of cells that are anti-inflammatory, kind of blue to cool things down, versus the inflammatory hot red cells. And there's a balance. The problem is there's not been studies done on patients, only on mice, and we know that mice don't always equal humans. So we don't have that information on humans to know in the ankylosing spondylitis spine, or for that matter, the peripheral joints, that enthesis that's in either the knee or the elbow or the ankle, or an inflamed enthesis. Do we have the same thing, or is there an imbalance? And that remains a bit of a black box. So finally, what do we need to get to the point of developing, or so where are we with regards to developing new treatments and prevention? And so I'm going to wrap up with kind of the new things in this regard. So my question for you now is, has your doctor asked you about any of the following? Eye symptoms, breathing problems, skin rashes, upset stomach, mood, exercise, or even the COVID vaccine?
We're just about at 60% right now.
Okay. I see the Q&A is starting to light up too. So.
Well, we have some excellent questions to get to. Yeah.
Oh, good.
Okay, I think we can end this poll now, Dr. Kuhn. What do you think?
Yeah, go for it. Okay, mostly eye symptoms and getting a COVID vaccine. So great, that's good to know. I think all of these things are important, and I like to ask my patients about all of these things because they can all be affected when you have spondyloarthritis. So, of course, the COVID vaccine is something that's a hot topic, and we'll cover that just in the last couple of slides. So, as I alluded to earlier, spondyloarthritis is not just about the joints. Of course, a lot of you said you get asked about eye symptoms, certainly. It affects the spine, it can affect peripheral joints. So I ask about these, about joints, but I ask about eyes, I ask about skin rashes, I ask about the gut too, because we know that up to half of the people with ankylosing spondylitis with no history of bowel inflammation could have what we call subclinical bowel inflammation. So they may not have a lot of symptoms or something that doesn't necessarily bother them, but they could still have inflammation that if a gastroenterologist did a colonoscopy would see some inflammation. Plus, we have to think about this when we think about treatment. And so this is not a comprehensive list. This is kind of a lot of the current therapies utilized for treatment of spondyloarthritis. And I'm not going to spend much more time other than to say that, choosing these drugs is going to be based on your personal history with what's worked, what hasn't worked, and what other tissues are inflamed beyond just the joints here. So the management is beyond just worrying about the joints, just worrying about those medications, but also worrying about a lot of things that can co-occur in spondyloarthritis. And so we have to worry about cardiovascular disease, such as blood pressure, cholesterol. If you're a smoker, we want you to stop smoking because that only adds more to your risk of developing cardiovascular disease. Obesity, because there's a lot of benefit to weight loss, not only for decreasing your spine symptoms, but also for decreasing that cardiovascular risk that you have an increased risk of. Diabetes, especially for individuals with psoriatic arthritis, we get very concerned about something called metabolic syndrome, where when you have psoriatic arthritis, you're at higher risk of developing obesity, cardiovascular disease, and diabetes. Inflammatory bowel disease, I always ask about gastrointestinal symptoms for the reasons I just said. Of course, eye disease, I think that's obvious. A lot of our patients with AS have eye inflammation. Malignancy, this is important. We should, especially for those who have had or have psoriasis, because for a long time, we treated psoriasis with UV light therapy. And so we need to make sure that there's no concern for the development of skin cancers. And then depression, anxiety. We know that depression and anxiety is of increased risk in individuals with spondyloarthritis. And so it's important that we ask about these symptoms of depression and anxiety of you, our patients, to make sure that your whole person is as healthy as can be. And then exercise. I like to talk to patients about exercise. And I always caveat this, that exercise doesn't have to be intense. We're going to train for a 5K or a marathon or a triathlon or anything like that. It really is about getting up and getting moving. And there's a lot of great information. I was reviewing this yesterday about the recommended exercises on the SAA website. So I would encourage you to go to the SAA website shown here to learn more about exercises. And there's some videos by physical therapists on what would be good programs. But we know the benefits of exercise aren't just about weight loss and cardiovascular health. It's also about, it's been shown in studies, and there was a really nice comprehensive review of all of the literature out there on exercise done just a couple years ago, showing that in ankylosing spondylitis, an exercise program compared to none improved physical function, mobility, and decreased a patient's pain and feelings that their disease was active. So these are great benefits of exercise. And finally, kind of the newest topic of management, of course, is COVID-19, as we're celebrating the year anniversary of this pandemic. And so what we have learned through the Global Rheumatology Alliance, as well as some efforts by the SAA to look at understanding how does COVID-19 affect patients with rheumatic diseases, as well as specifically spondyloarthritis. And what we have learned is that those who are above the age of 65 have underlying cardiovascular disease with high blood pressure, those who have lung disease, or those who are using steroids like prednisone of 10 or more milligrams a day tend to do worse. Now, those who tended to do well didn't have these features. And one thing that I've been talking a lot about with patients is that there is some limited data, it's not conclusive, but I think a lot of the concern was when the pandemic first hit is, I want to hold my TNF inhibitor. I know I'm going to not feel great, but I want to hold it because I don't want to get sick. And my doctor said, if I get sick, I need to hold my TNF inhibitor. It's still true. But it turns out that people who got COVID while on a TNF inhibitor and then subsequently held it, in some studies actually did better. And in other studies, they didn't do better, but they didn't do worse. So we know, at least with TNF inhibitors, that they don't give you a poorer prognosis. We don't have as much detail on other biologic medications. And there's some new information kind of coming out daily as that continues to get updated as we collect data from rheumatology patients around the world when they get exposed to COVID. What about vaccination? It's exciting. The recommendation now, and I am a big believer in this, get as vaccinated as soon as it is offered. There are very few reasons not to get vaccinated. I would encourage both you and your family members to get vaccinated if it's offered to you. Now, I think a big question that we're getting asked in our clinics is which vaccine? Doesn't matter. Anyone is good. And we're getting questions about, do I need to do anything with my medicines? And there's no adjustment that's needed for most of the medicines or biologics. Exceptions are for these few drugs. So methotrexate, tofacitinib, or the brand name is Xeljanz, abatacept, brand name Orencia, or cyclophosphamide, brand name Cytoxan, and rituximab, brand name Rituxan. I think in most of you, if you're on any of these, you might be on methotrexate or Xeljanz. I doubt most patients with spondyloarthritis, I don't use these other drugs. Nevertheless, the Spondylitis website has a really nice summary of these recommendations. And you should talk to your rheumatologist if you are on one of these exceptions to get guidance on what you should do once you've scheduled your COVID vaccine. But if you're really just on a TNF inhibitor like Enbrel or Humira, you can just go ahead and get it as scheduled without having to change the use or your schedule for taking your medication. So at this point, I'm going to say thank you for inviting me and having me. I really appreciated the attention, the participation in the polls. I threw in one last poll to let me know how I did. 1, great, you learned a lot. 2 was good, you got some new information. 3, it was not new, but you enjoyed the refresher, could use some improvement with regards to better, more relevant content, or really the last one, 5, like I hated it, but I'm gonna nicely say like improvement is needed. So thank you for your attention. And I think we'll finish this poll and go to the Q&A. Oh, and I'll say anybody has questions, you're more than welcome to contact me through this email address here.
Okay, and ending polling now.
Thanks. Oh, good. Thanks. We can go ahead and start the Q&A.
So sounds like it was a wonderful presentation, and I completely concur. Thank you so much, Dr. Kuhn, for that just really fantastic presentation. It was very interesting for me, and I'm sure it was for all of our attendees. So we are now moving into our Q&A session. I do have a high number of questions already, but if you still have some that you would like to submit to us, you can still do so. Please submit them in the Q&A module at the bottom of your screen, and we'll read them out loud for Dr. Kuhn to answer. And just a reminder, if you can please keep your questions in general in nature for everyone in attendance. Okay, so let's start up here. Is peripheral spondylitis a category? My areas are heavily in the hips and shoulders, and to a lesser degree the knees and sacroiliitis, no spine involvement. And one uveitis episode, also diagnosed with ulcerative colitis at age 22.
Yeah, so I think you'll get a little variance on what gets written in your medical chart as far as the diagnosis. But when we approach making a diagnosis of spondyloarthritis, we do think about 2 ways. We go, is it peripheral or is it axial? And certainly people can have both. But it's usually what is predominant. And so it sounds like predominantly peripheral spondyloarthritis here. And then once we've decided, are you predominantly axial, are you predominantly peripheral, we'll say, okay, what are the associated factors? And so if you're peripheral, we tend to see it associated with like psoriasis or IBD, so ulcerative colitis. But I also see that a lot with axial. I also see a lot of times where it's not associated with another underlying disease. And so I think what label gets put in the chart a lot of times is semantic. And the treatment is really going to be based on what is it? Because we know certain medications do better for peripheral versus axial disease. And then we know that certain medications can't be used, say, in the setting of IBD, so we'll avoid them. Or we know that some medications will be better in the setting of eye disease, so we'll go that way. Even if it's a remote history of eye disease, it's still such a terrible thing to have to experience that we don't want you to have that again. And so we'll try to select something that's going to be more protective for the eyes than something that's not as not thought to help with the eyes. So I think for sure we get, and that's where like these natural history studies and really like fine phenotyping and understanding like what are the different buckets patients have that they're fitting into, and what are these patterns that we're seeing, and can we learn anything from the biology that distinguishes them from other buckets.
Thank you. Next question is, could you say more about the cardiovascular risk for someone with AS? The link is new to the person asking the question.
Sure. So anybody with a chronic inflammatory disease, whether it be spondyloarthritis, psoriasis, psoriatic arthritis, or even rheumatoid arthritis, we see that chronic inflammation has been linked to an increased risk of developing cardiovascular disease. And by that, we mean things that are like heart disease, so atherosclerosis or hardening of the arteries. And so the routine screening that any doctor would do for that is basically blood pressure, cholesterol. And so we got to make sure that those risks or that we're following those. I think there's debate in the field with rheumatologists, like how much of that is like our primary responsibility versus the primary care doctor's responsibility. And so I think it's really good as long as it's getting addressed. So a lot of times what I will do is see, has it been addressed? If it's not, I might ask the primary doc to say, hey, my patient is at increased risk of cardiovascular disease. At their next annual exam, please consider checking a fasting cholesterol panel. And you know, if outside of goal, please work with the patient on ways to mitigate their risk. So there is increased risk of other heart issues. And I think the SAA was involved with these guidelines too, correct me if I'm wrong. But the guidelines for the management of patients with ankylosing spondylitis did not recommend, despite an increased risk of arrhythmias, meaning the way the heartbeat, that rhythm can get different. And so things like heart block, where it doesn't beat regularly, or AFib, where it can beat irregularly and kind of go in and out of a fast pace. Those kinds of things, or there can be problems with the aorta coming out of the heart. And the recommendations were not to do any kind of routine screening. And so you have to follow if there's like a family history or other things to consider should you be screening for that. And so that's where just, you know, a good, put the stethoscope on you and, you know, as a doctor, have them listen to your heart and make sure things just sound normal, that your pulse feels regular. There's no new murmurs, things like that is really what I would recommend doing.
Thank you. What are the current medical criteria for prescribing biologics? What is the list of specific symptoms, or, you know, basically how you determine when it's time for a person to go on a biologic?
Yeah, a lot of factors go into that decision. So according to the guidelines set forth between a lot of the medical societies who treat spondyloarthritis, which came out a couple of years ago. I think there's a link to them on the SAA website. I think they put them in kind of a patient language on these recommendations, and it's on the spondylitis.org website. So the first line, once you've diagnosed spondyloarthritis, the first line of therapy are something called NSAIDs, anti-inflammatories. These are things like ibuprofen or naproxen, Advil, Aleve. And being on those as scheduled, meaning you don't take them when you need them, you actually take them twice or 3 times a day, every day. The guidelines suggest that we do a trial of at least 2 different kinds of medicines in that category for a total of at least 4 weeks. If that fails, then you would go on to a biologic, and the first line biologic preferred are these things called TNF inhibitors. TNF being a chemical of inflammation that's important in spondyloarthritis, that we need to kind of reduce that inflammation from that chemical. And those medications can be things like etanercept, or Enbrel is the brand name, adalimumab or Humira. Those tend to be the most frequently used ones, I would say, because they're the oldest. And we'll utilize those. A lot of docs will say you've got to give it at least a 3-month trial to see. Now, before you go on to those medications, there's risks involved with those medicines. And so we need to do some blood work. And so all of these medications have an increased risk of making an infection bloom if you have an infection. And so certain infections you may not have symptoms of, for example, tuberculosis or viral hepatitis, so hepatitis B or hepatitis C. So we routinely check for those. It's also very good practice to check for an HIV in these settings. And so I add that to my screening panel before anybody goes on a biologic. If those are all negative, then we'll go on to a TNF inhibitor. Now, other things may factor into it. We know that TNF inhibitors we can't use in somebody who has heart failure. So if you have heart failure, we may skip that class and go to something else. So it's very unique to each patient and what their symptoms are. That's what I've talked about really is for axial disease. If it's peripheral, we may go a different direction because we know that there's some other oral medicines like methotrexate or sulfasalazine that can help with peripheral disease, and you may want to do that before going to a biologic.
Thank you. Is there a blood test to confirm that a biologic is working?
Good question. Not really. Unfortunately, no. We do sometimes test if, say, you've been on Humira for a while and all of a sudden it quit working. Sometimes we will test to see if you have adequate blood levels of the drug, making sure that you're getting enough of the medication into your body. And we can check for what we call antibodies to the drug, because we know that as much as we try to make these medications, these biologics, as human as possible, they're still not made by you. And so there's a risk that your immune system will eventually attack the medication and make it ineffective. And so we can test to see if you've developed those antibodies. And that can help us decide if we want to continue on that drug or switch to something else.
Wonderful, thank you. Next comment is, thank you so much for the presentation. It's been great. Question on depression and anxiety. You mentioned people are at higher risk of depression and anxiety with SPA. Why is that? Is it genetic, something else?
It's a good question. And it's not a literature that I am as familiar with. I remember a few years back, there was some thought that this inflammation chemical TNF, there was some thought that that might actually contribute to depression and anxiety. And so maybe is it because of the spondyloarthritis, you have this increased TNF inflammation chemical, and that is also triggering depression, anxiety. But they tried, I think there was a small trial of looking at TNF inhibitors for depression, and it failed, it didn't work. So it's not clear, is all I can say. And my superficial, it's very superficial understanding of that. So I apologize.
Thank you very much. I have a slew of questions about the COVID-19 vaccine, so I'm going to do my best to kind of compile them into one. So, can people with AS take the COVID vaccination? Do you trust the science about the long-term potential side effects? What if you've had a bad reaction, such as a sulfur allergy? And is there, one that is more recommended over the other?
Yeah. So great questions. So first, if you have spondylitis, you can get the vaccine, definitely. There's no reason for you not to get the vaccine. We are recommending the vaccine for all of our patients with rheumatic diseases. So not just spondyloarthritis, but even if you have lupus, even if you have rheumatoid arthritis, all of our patients, we're recommending it. And we think it's very safe and very effective based on the science that has been reviewed. The American College of Rheumatology put together a panel of experts who are rheumatologists that study vaccination in our patient populations. And they put together all of the evidence in February and came out with these recommendations. I think the data is very solid that the vaccines are effective. I don't recommend one over the other. I think at this point, if you can get vaccinated, you should just get vaccinated and not try to wait for one or the other. I can tell you both Moderna and Pfizer have I think this is where people are concerned because it's a newer technology. And people are concerned because of how fast it came to light to utilize these vaccines because it's a different technology. But I think where we as a medical community have failed to communicate with the public is that even though this is a new technology in medicine means it's been around for 10 or 15 years. And so it is very safe and it's been in development for a very long time. It's just, it took a new virus like this for us to have the opportunity to use it. And so even though these are the first vaccines utilizing this technology, we've been studying it and testing it for years and years and years. I think the risk of a side effect of these vaccines is the same as any other vaccine that we've been doing for a long time. There's always a small risk of having an adverse reaction to a vaccine, just like there's always a small risk of having an adverse reaction to a new medication that you take. And so I think that's about as much as I can really say to that. I've gotten it, my family's getting it, that's all I can say to reassure people. It was really cute. My son, who's 10, has already said if they start testing in children, he's like, I want to volunteer. It's
wow.
That's so sweet. And even as a mom, I think these are safe enough that I would let him. So hopefully that helps reassure those who have concerns. I am not aware of any contraindication because of a sulfa allergy. But that would be something I'd have to look into, or I would encourage that person who asked the question to check with their physician to just confirm that they can have it. But I'm not aware of any reason they couldn't.
Thank you. Such a wonderful answer. Okay, so there's a few questions about kind of longer standing spondyloarthritis. One is, why can AS affect breathing? Does it have to do with fusion of the sternum? And then to kind of maybe broaden that question up a little bit, what are some of the kind of long-standing disease complications or comorbidities that people who are older and have had this for a while should be aware of?
For sure. So first, with regards to breathing, yes, because where your ribs connect to your spine and your back, that can get fused, and you need your rib cage to be able to expand and contract for breathing. And with that fusion, it restricts it. And so that's why breathing can get harder as you fuse up your back and get older. The other, so that's where exercise can be really important, because the exercise has been shown to help increase your range of motion. And that exercise, when you start to do any kind of cardiovascular work, you have an increased work of breathing. And so that helps somewhat there. Another thing that can help is something we call incentive spirometry. If anybody's had surgery or seen somebody who has surgery, they've seen it. It's this little contraption that has it's clear and it's got these blue pieces and a ball, and you have to breathe in real slow and real deep and try to get the ball to a certain level. And those things can be really helpful as kind of chest exercises to help with that range of motion and get better breathing. A very rare complication that can affect breathing is the tops of the lungs. So what we call the apices, or the tips of the lungs in the higher chest. can also get some inflammation in the lung tissue itself and affect breathing. And this is where just, us as doctors, listening to our patients' lungs is important, to see if we hear, because it kind of actually sounds like, when this happens, you get this like this Velcro, that sound of Velcro coming apart. And when a patient breathes in and out, it can kind of sound like that. And that's why it's important to listen for it. As far as other long-term complications, I think there's some other very rare ones, like I talked about, kind of the heart issues of where you get the beating pattern can get disrupted, or the aorta can widen. Those are pretty rare and unusual complications, but they're known to happen. A few other things that are probably a little bit more concerning that I would tell patients who've lived with the disease for a long time should really be aware of. Number one is fracture. In my patients who are fully fused, this is probably my top worry, and I counsel them on, if you get into any kind of accident, like even if you're just barely rear-ended in your car, I want an x-ray, because even though you've built extra bone along the spine, it's not good bone, it's fragile bone, and it's prone to fracture. And so just a small blunt force like that is enough to fracture the spine. And I would want an x-ray to make sure that we don't need to go in and stabilize it because there is a small fracture. So that's probably like the most serious complication that I warn people about. That being said too, is that you also, once you have your spine fully fused, we don't want you being in any kind of sports or activities where you're likely to get that kind of injury. So, no horseback riding and things like that, because we don't want to increase a risk of you having a spinal injury. The other thing that I think is important to consider is osteoporosis. And so all of our patients, as they age, are at risk for osteoporosis. And again, like I said, that bone is not good bone. It gets a little challenging because anybody who's had a bone density screen knows that we base the bone density off of the spine as well as the hips. And so we can't really utilize that information from the spine in somebody with ankylosing spondylitis. So we really need to look at the hips. We can also look at the radius, the wrist, and look at it there to make sure that they don't have osteoporosis. And then we have to tweak the treatment of osteoporosis in ankylosing spondylitis a little bit differently than we would with somebody who doesn't have AS, just because of the way the medications work with building bone. So, yeah.
Thank you so much. That was such an excellent answer. Is leaky gut the same as what you're studying in the microbiome, or is it related in any way? And if so, can leaky gut be reversed, and how?
Yeah. So leaky gut is, I think, is an important concern that people have. And I think we don't really understand, like, I think, yeah, I would say that it's probably what I was talking about, is trying to understand how is what's going on in our gut connected to the development of inflammation and joint disease. And how do we modulate that? I think the only data we have for modulating it that's going to be effective would be something like what I had said with regards to diet, of eating a plant-based diet, food that is as little processed as possible. And with regards to meats, you are eating lean meats, things that are high in omega-3 fatty acids, as well as whole grains. And so when you eat breads and pastas and things like that, you're switching out and utilizing whole grains as much as possible. But I'm the first person to tell you that I'm not going to pass up a cupcake on a birthday. So I don't think you have to be incredibly strict. And I don't think you have to go fully towards what you can read online, like the anti-inflammatory diet. Like, I know that there's a lot of information about the anti-inflammatory diet, and you should be avoiding nightshades and things like that. But when you go into the scientific literature and look at what we've been able to do from a biology response to these kinds of diets, we don't see those concrete effects. That being said, if you feel better on it, I'm not gonna say no, don't do it, because they're very low risk and minimal harm, no harm really to do them. So I know I'm really cagey about it, but it's really because we don't have great science to guide us.
Thank you. And actually, the next presentation, Dr. Sohadola Tabari will focus a bit more on nutrition. So we'll
Good,
have some great information come out of that as well.
good.
Next question. What baseline numbers are considered elevated CRP?
It's tricky. So there's two types of CRP that can be tested. One is a high sensitivity CRP.
And so sorry, can we maybe define what CRP is for those of us who aren't 100%
Oh yeah,
sure?
thank you. So CRP is a C-reactive protein. It is produced by the liver when the body has inflammation. It tends to go up and down rather quickly. And so I feel that when we test CRP, sometimes we miss it because it can go up and down so quickly. Now, there are two forms of this inflammation chemical that we measure: the high sensitivity CRP or just a regular CRP. And each lab will have a different cutoff for those. It's hard because with the high sensitivity, I can't remember if it's at 2 or 5 is the upper limit where they cut it off. With the regular C-reactive protein or CRP, it's a 10 that we cut off here. Now, if you come in and you're at 11 or a 12, I'm kind of like, that's not really impressive. But if you come on in and you're like in the 20s or higher, then that's a lot more impressive. But I remember one of my teachers teaching me, you get an MD or a CRP, but you can't have both. And that was to mean that you've got to use your patient's history to help you inform and understand if they're inflamed. And I think that's important because if you come in and your C-reactive protein is at 20 and you started developing a cough and a fever yesterday, but you also have AS, I'm pretty sure that CRP is going to be due to that cough and fever and not because of the AS. And so that's where the CRP can be problematic, is because it's not specific to anything. It's just a generic marker of inflammation. Where it gets really difficult to use is those people who have both spondylitis and IBD. And it's really hard because you don't know if that increased C-reactive protein is because maybe the bowel is starting to flare, or is it because the joints are starting to flare, or maybe they have also some skin things like psoriasis. Is the psoriasis about to flare or flaring? And so that's where the CRP can get really difficult, and why it needs to be utilized within the context and not just a value.
Thank you so much. What are some good things to do to prevent osteoporosis? Anything different than someone without AS?
Not anything different. I mean, really, it's the same thing. So exercise is good for increasing bone density, as well as making sure your vitamin D level is adequate, and maybe taking a vitamin D supplement if you need to, and then making sure you get enough calcium during the day. So we recommend usually around 1,500 milligrams of calcium. And you can say each supplement of calcium is about 500 milligrams. And so you need either 3 supplements a day, or you can substitute them out: glass of milk, cup of yogurt, piece of cheese, and then you get to your calcium in the day. So it just depends on what your diet is like and if you want to take a supplement.
Thank you. I'm going to kind of combine 2 questions into one. So once you go off a medication like a biologic or something differently, and then try to go back on, is it true that medication may not work as well or may not work at all? And then kind of similarly, why do biologics stop working sometimes after a while and you have to switch?
Yeah, those are great questions. And I think they're just as perplexing for patients and clinicians. So it is true, and we worry about this, that if you stop a biologic, and then you go back on it, will it work as well? And we don't know. For some people, it's fine. For other people, it doesn't work the second time they go on it. And why that is, we don't know. We know that if you start, stop, start, stop, start, the same medication, what I was talking about, those developing antibodies that can kind of neutralize the effect of the medication or block the medication from working. When you start and stop medications, the same biologic over and over, your risk of getting those kinds of antibodies goes up a little bit. So there might be some of that. Same reason, why do people lose efficacy? You know, you've been on the Enbrel for 2 years, and why is it no longer working? And, you know, sometimes it's because of antibodies. Sometimes we don't have a great reason why. And it's frustrating. I don't have great answers for that. I wish we knew.
Thank you. Again, kind of combining two, are there specialty clinics for spondyloarthritis versus just general rheumatology? And how can someone locate something like this? And also, do you see new patients in a remote mode? I need to be diagnosed by an expert.
Okay. So yeah, so there are some specialty spondyloarthritis clinics throughout the country. And I don't know, Eileen, do you guys have a list of those on your website or not? I don't think so.
You know, not the specialty clinic, so that is an excellent idea. We have a rheumatologist directory, a patient recommended directory.
Okay.
But as far as the actual, you know, the spa focused centers, we don't, and we really should. That's
Yeah.
excellent.
Yeah, because I know we have it here at Colorado. I'm trying to think. Well, of course, UCSF has one. Oregon, Houston. I'm like thinking of the US map right now, and I could tell you places. Boston, of course, there's several in Boston. I'd have to think if there's more. Cleveland, I believe, does too. So there are some, and there's probably a lot more than what we know about, but that could be a really interesting thing to put together. As far as patients,
I'm sorry to interrupt. Could I ask the person who sent that question, please email that to programs@spondylitis.org. We will get to work on creating that, and we'll share it with you and everyone else. Thank you very much.
Yes, I am taking new patients here in Aurora, Colorado, at our clinic. I will caveat that I only have a half day of clinic a week, so it's tight to get in to see me because the rest of the week I'm running a research program. So, and as far as, you know, being able to see patients, I see patients mostly within the Mountain West region just because of location. And I do see, we do telehealth as well, but telehealth, the laws and the rules keep changing on us. COVID was great in that we were able to expand telehealth universally for all rheumatologists, but then with regards to each place, it just depends on whether or not your state will allow you to do telehealth outside of the state and in licensure and things like that. So it's weird because I can see patients who are in New Mexico and Wyoming, but I can't see patients in Kansas, which is closer to us than Wyoming or New Mexico sometimes. So it just depends on the
No
law.
rhyme or reason.
Yeah, exactly. I do think a spondylitis clinic is good, but of course I'm biased because I run one. And the reason for that is I think our patients have a lot of unique needs that if your rheumatologist isn't used to dealing with a lot of spondy, they may not understand some of the nuances that this disease can present. And so I think for people who have complicated disease, it can be hard. And, you know, and I don't want to put down any other physicians or promote, I think, you know, I'll be the first person to tell you though, that like, you know, I'm really comfortable with spondy. I am not comfortable with things like lupus. So And so I think it's really important that as a physician, I be able to acknowledge what my strengths and weaknesses are. And I think I would say that that would be important for a lot of other physicians too. And I think it's fair for you as a patient to say, how comfortable are you with this disease? So.
Thank you. A comment and then a question. One really nice thing I want to share. Someone says, "I'm also an elementary teacher, and I have to say you're an excellent educator," and I completely agree. A question: I have used 3 TNF inhibitors so far with no help. I have AS. What should happen next, in your opinion?
Ooh, so that's hard. I mean, I think the guidelines would tell us that you would try 2 or 3 TNF inhibitors, and after that fails, you would then go on to another class of medications. And so you would move out of that TNF inhibitor class, and move into something else. Like, would you go down towards like an IL-17 inhibitor, for which there are 2 FDA approved medications, Cosentyx and Taltz? Or would you go into something a little bit more different, Stelara being another one that's approved? Or, are there other options that you would want to discuss? And I think, without knowing a lot of details, it's hard to say, but that has to be tailored to not just having the spondylitis, but also tailored to any other medical issues that you have. And we need to, it'd have to be personalized to you based on those things.
You mentioned Stelara. Can we just discuss what that is? And then, kind of to broaden that earlier question, what alternatives to biologics are there? Specifically, are there any medications that don't impact the immune system?
So yeah, good question. Are there some that don't impact the immune system? No, in short, no. I think the main one that you can do are the NSAIDs, the anti-inflammatories like ibuprofen and naproxen. A lot of people like indomethacin and diclofenac as well in that class. And those are going to be the least immune modulatory. So meaning they'll have the least impact on the immune system. But of course, they have their own side effects and risks, mostly being upset GI and development of stomach ulcers that we worry about with those medications. So when it comes to biologics, I think that's the second line. But if you ask me, that's probably the mainstay of treatment for people with ankylosing spondylitis and most other forms of spondyloarthritis. And, so we talk a lot about TNF inhibitors because I think we've got a long track record with them and we know they work really well. So then, there's the IL-17 inhibitors. We briefly mentioned those. Now, what is Stelara? Stelara, or ustekinumab, is a medication that hits another set of inflammation chemicals. These are the chemicals called IL-12 and IL-23 in combination. It hits both of them. And that's approved for the treatment of psoriatic arthritis and spondyloarthritis. And then beyond the biologics, say you cycle through all the biologics and it's not working, or for some reason you can't take a biologic. Maybe you have an immune deficiency and we can't use that, then what do we do? And that gets really challenging. We can piece together medications like if you also have psoriasis, we can utilize something called apremilast. Brand name is called Otezla. It hits an inflammation chemical that isn't as connected to the immune system. Most docs would say it's a rather wimpy drug. That being said, it can be really good as an adjunctive therapy or an add-on sometimes. And then, there's some newer classes of medications called JAK inhibitors, JAK. It's a class, and in that class are things like Xeljanz, Rinvoq. There's another one out, and I forget its brand name, that are coming out. They're mostly used in the setting of rheumatoid arthritis and psoriatic arthritis. but there's encouraging data for spondyloarthritis. However, those medications, rather than working on the inflammation chemicals themselves, they actually block what the inflammation chemical does inside the cell. So they're still working on the immune system. I think a brilliant drug would be something that works. I mean, this is of course my bias, so take this with a grain of salt if you will. I think I would love to see on the horizon the development of drug that could manipulate the microbiome. And this is where I get into like my prevention. If we know who's at highest risk, can we start manipulating the microbiome and the chemicals that the bacteria make that stimulate the immune response so that we can kind of keep that from ever happening in the first place? But that's a goal, and it probably won't be until the end of my career that we can see any of that come to fruition. So.
Okay. Thank you very much, Dr. Kuhn. We're actually out of time. And thank you everyone for these wonderful questions. I have to say they were so interesting, so varied. And Dr. Kuhn, I think it was really informative for everyone. So thank you again for spending this time with us.
My pleasure. Thank you for having me.
SAA is a nonprofit organization focused on meeting the needs of the spondylitis community. We are committed to research, support, education, and advocacy, and we couldn't do any of it without the support of our members and donors. So big thanks to you for making today's program possible and for your ongoing support. Big thanks also to Novartis and AbbVie for their financial support of this program provided through educational grants.